I'm really happy that you're all able to be here, and I'm excited that we can share some of the updates in lung cancer. So if there's one thing that you take away from this talk, I hope it's just one of hope. You know, this is not a talk we could have had 30 years ago. There wasn't a lot changing, but there is so much happening in lung cancer. You know, I go to lung cancer meetings, research meetings several times a year, and every time I'm talking about new drugs that have been approved and new techniques that are being used, and really a lot. So first thing I just want to point out is that people, for the first time in years, patients are living longer than ever before. And we, you know, again, weren't able to say this 10 years ago, but things have really, really over the last 5-10 years. And when we think about why this is, you know, two things jump to mind. One is that we're screening people for cancer. So this is known that this is important for a while, but really there's been a push more recently. And the idea is that if we can screen early, catch cancer in the early stages, surgery and radiation can cure it. And so that's what we're trying to. And so, you know, even though we really want to encourage people to get screened, you know, it doesn't happen as it like it to. So it's good here for us. But anyone who's, you know, 50 to 80 who smoke currently or smoked in the past and had about 20 pack years, so you 20 packs a day, how many, at least 20, then you think the benefits of screening are, you know, outweigh the risks. And so we really encourage anyone in that criteria to get screened. Other thing that's really changed, and this is where I'll focus most of my talk, is that our understanding of lung cancer has evolved. So we used to think of lung cancer as one entity. We've now come to understand, we then got to the point of breaking it up. Okay, there's small cell and non-small, histologic differentiation. And then we got to the point where we're understanding further breakdown of non-small to different cells. And then the areas that are really growing now are understanding the molecular features. And so what are the changes in the genes, in the cancer, that led that cancer to develop? And it's exciting because those are areas we can target. And then the other piece that also understanding is how the cancer interacts. Understanding of the disease. So I just wanted to take a moment and kind of go through how we think about lung cancer treatment. And so at the very base level, there is cancer of the cells in the airway, the lung breakness, oxygen. So cancer cells that grow uncontrolled anywhere in the. And we think about staging lung cancer based off of how far it's spread. That helps inform us in terms of what our treatment options. So stage 1, early stage, is just cancer in the lung tissue itself, in one area usually. Stages 2 and 3, we've got cancer that's gone into the lymph nodes. The differentiation there is how many lymph nodes and how big and where they're located. And then stage 4 is when cancer moves outside of. So as we kind of talk about lung cancer and the treatment, staging will come guide treatment. And so we have 3 big buckets of 3 tools we can use for treatment. I won't talk about surgery and radiation today because that's not piece, but those we always look at, especially in the earlier stage setting. And then systemic therapy, meaning anything that you take in either orally or through an IV that goes throughout the entire body. That's what we'll do. Okay. And that can be broken down into chemotherapy, immunotherapy, and therapy. So everyone, I think, is very familiar with chemotherapy, or you know someone who's gone through it and had it. Chemotherapy is not very specific. So, you know, cancer Basically, it works by injecting a toxin into cells that are rapidly growing. And so this is cancer cells. Cancer cells grow fast. Take advantage of that by giving them that can. There are other cells in the body that grow quickly. Bone marrow, things, GI tract, that sort of thing. And so we get a lot of side effects. It's very effective, but it's not very specific. So another tool we have is immunotherapy. The way I like to talk about this is that your immune system is supposed to recognize things that are foreign. Viruses, bacteria, cancer cells should recognize foreign and get rid of them. And cancer, for some reason, is able to find a way around them. It's able to grow unchecked without recognizing. And in many ways, the cancer can be smart and downregulate your own immune system. It'll turn off specific pathways that you normally use. So immune therapy is supposed to help your immune system recognize it, get rid of it. So this is a very exciting area. And then finally, another area we'll talk about is targeted therapy. And so again, this is looking at why do cancer, and usually it's because there's mutations in growth pathways cells that lets them grow unchecked. And so a lot of our targeted therapies are designed to find those specific mutations and interrupt that. And so we'll talk about this more. This is an area of lung cancer, and we can be very successful. So like I said, we break cancer down into non-small cell and small cell. And as there's sort of a trend where most new technology and treatments start in the advanced setting, and then we move it earlier and earlier. So this is where we start advanced. And when I say advanced, I mean 3 or 4. So, someone comes in, they have a new diagnosis of lung cancer. How do we decide out of all of our treatments what we're going to and of course, there's a lot of patient factors, how they're feeling, what medical problems they have. But there's the tumor-related factors. And so for every lung cancer patient that I see, there's 2 types of tests I do. And this is an advanced lung cancer. One is I look for targeted mutations. So that's the first thing I want to look for. Is there a mutation I can identify that I can target with medicine? That's this path. Their target and if there's not a target, then I look at markers for immune therapy. And you'll see this come up a few times on the slide. The abbreviation is called P1. It just refers to the stain that we use, marker we use to. So if there's no target, then I'll look at would they respond to it. So this is amazing, and this gets updated every year as we learn more and more. We know that in non-small cell, in non-squamous, subtype, there are targets in about 70% of patients. So down here, down here that doesn't have any is about 30%. But our most common mutations in called KRAS, EGFR, and now those are the most common. There are other ones as well, 1 to 2%. But certainly these 3 are what we see the most of. And very excitingly, we just had a new drug approved for KRAS. For many years, we didn't have anything to offer. So this is just to show that when I'm sending off a sequencing panel for lung cancer, I'm looking at all of these genes. So maybe a little bit too small, but just see the vast number that we're looking at. EGFR, ALK, ROS, RAS, and all of these. And that's because we know that time and time again, when we're giving treatment, first-line treatment, if we can do targeted treatment, that leads to people feeling better and better survival. And so for each one of these, we have multiple therapies. So EGFR was kind of one of the first targets in our, about 10 years ago, almost now. And since then, we now have 5 or 6 treatments in the EGFR space, about 4 or 5 for ALK, 2 for all of the rest of these. KRAS just had one of but there are, look at how many treatment options. And that's the takeaway from this, is not knowing all the different names, but how many options we have and how important it is that we're sequencing first. Now, there are barriers to testing. Sometimes there's not enough tissue. You have to have a tissue biopsy usually. We'll talk about exceptions to that, but we like to have the actual tissue. It can take a while. There can be insurance issues. So there are things that come up where testing doesn't happen. Of course, we were diagnosed many, many years ago, and we weren't routinely doing it. For the issue of tissue, this is another really interesting area. Moving into the space of liquid biopsy. So it used to be that you had to go stick a needle in the tumor to test it. There was no other way. And for whatever, for some people, that's not either hard to go get a biopsy, or it's in a bad location, or, and you have to go through that procedure. Sort of in the last few years, what we've been able to do is use a blood test to get the same information. Now, it's not perfect. I don't use this as the first test. I like to use tissue because that's the gold standard. But the way this works is as a tumor dies, so cells in the cancer are constantly growing and dying. They break open and release protein and DNA, and that gets picked up in the bloodstream. And then you take some blood, you sample of blood, and you can find those pieces from the cancer. So there is a lot of application of this potentially, and we're still there's a lot of trials in this space to see, like, in someone who had early stage cancer and was removed, we use a liquid biopsy to figure out if they're going to recur. Can we pick that up before even the CT scans we do? So there's a lot of potential here, and this is an area that we're. And then this is a purposefully very busy slide to show you just a subset of how many clinical trials there are. So I talked about all of those new medications, and there are many, many, many more trials in them. So more to come. So we talked about targeted. What about don't have a target? Talk a little bit about immune therapy. And the way that it's not a perfect test, but probably the best way that we have to know if someone might respond to immune therapy is through a test called PD-1. And it's just a test we do on the tissue. Pathologists do it. They look under the microscope. We think the higher the number, the more likely there is to be a response. And so this is just showing that for really high levels of one of that immune therapy marker, we can do immune therapy alone. If you have kind of intermediate levels, we think that immune therapy combined with chemotherapy is the best way to go. Different rationale behind that, therapy kind of breaking open like cancer cells, helping immune therapy work. And if you have no PD-L1 expression, we think that either chemotherapy alone or sometimes added immune therapy. So we use that to kind of stratify, and this is based off of trials that stratify patients. Use that to help decide what combination. So what about earlier stages? So stage 1, 2, even 3, where we're, and like I mentioned before, we take treatments that we learned about or are approved in the stage 4 setting, we've had earlier and earlier cure rates, because we know even when we can do surgery and radiation, I think we get everything, cancer can come back. And so our goal is to really try to optimize treatment in the early stage settings. And so this is one of the most exciting trials in the early stage space. So one of the EGFR drugs that I mentioned, Tagrisso, we were for many years only using the EGFR medication, targeted treatments in the advanced stage. And it wasn't because we hadn't tried before. There'd been other trials in other EGFR medications that had no improvement. But for the first time, we saw that if you give in people with EGFR mutations, if we give that targeted treatment, that Tagrisso, after they have surgery, chemotherapy, we help them live longer without the cancer. So that's now been improved in that setting after surgery and chemotherapy. So it's actually the only targeted treatment right now that we're using in the early stage setting. So this is fairly new. There are other studies looking at other targeted treatments after surgery and chemotherapy, but that has not read out yet. The other thing that we're finally doing in the early stage setting is adding immune therapy. So, again, historically after surgery, if you need chemotherapy, we did 4 treatments of chemotherapy in the study. And we know that helps people live longer, but it was just a little bit longer. It wasn't a substantial benefit. This is very, very recent data. It's not fully mature, but it's from a recent study showing that adding immune therapy after chemotherapy also helps patients without cancer. So this is an area that we're now at. You have to have a certain level of that PD-L1 marker to qualify for this, for us to think that there's a benefit. That's above 1%. But again, an area that really exciting. And then I just going to briefly talk a little bit about small cells. So this is an area that's been harder to treat than non-small cell. We've, not for lack of trying, there's been a lot of trials. It's just a little bit more of an aggressive cancer. But there's been a lot of data recently, and we're excited to have a study. So targeted treatments in small cell are not very successful. Immune therapy, though, has been. There are several studies highlighted up here that have shown very equal. There's different immune therapy medications. All of them have shown about the same benefit, so they're fairly interchangeable. One that I frequently use is the combination of using chemotherapy plus an immune therapy called Centric. And that's based off data that showed significant improvement in health. Added that in. So that therapy in small cell has been fairly recent and wonderful treatment for patients. And the other thing that's been very recently is a second line treatment. And that also for the first time showed improvement along patients with small cell. And did so in a way that wasn't terribly hard on the body. So I'm really excited to have those new treatments for small cells, having options for me. And again, busy slide purposefully to show you that there's a lot in the pipeline. A lot of other types of immunotherapy trials. They're even trying to do some targeted treatments. So there's a lot. Trial here open for. So I just wanted to stop here and that there's a lot going on in lung cancer, a lot of advanced. There's a lot to really be focused. So I wanted to leave you with that message. There's also some wonderful patient advocacy groups. So many of the targeted therapies have their own advocacy groups, so like the EGFR registers, ALK wonders for ALK positive lung cancer, for ALK positive ROS wonders. So there's many different patient advocacy groups. These are national groups, and then as well as we have a lot of information here from Longevity, National Lung Cancer Advocacy. So with that, just wanted to thank you all for being here, and we have some wonderful presenters as well for the community. I just wanted to briefly, so we're done. Please grab some more food, and I'm available to answer